Hi, welcome everyone. Thanks for joining us for the April 2018 CDA vendor webinar. This webinar is being re-recorded. Some slides will be presented by someone else other than what's addressed on the slide. I am Mindy Durrance and will be presenting along with my colleagues Dan Pollock, Janetta Bell, Casey Thompson, Wendy Wise, Ahmed Tahir, and Amy Webb. We will be presenting primarily CDA-related information that applies to the 2018 April and July releases and the 2019 January release. The webinar will be posted on the NHSN website. We have a lot to present, so let's get started. Next slide. Next, we'll talk about the APEC meeting. Next slide. This year's APEC meeting will be held June the 13th through the 15th in Minneapolis, Minnesota at the Minneapolis Convention Center. The NHSN members meeting will be held Thursday from 5 to 6:30 p.m. in Auditorium 3. NHSN subject matter experts will be presenting important updates for 2018 and 2019. Next slide. The Vendor 101 meetings will be held Tuesday and Wednesday and Thursday if needed. These one-on-one conversations between your company and NHSN provide an opportunity for you to communicate directly any specific questions or concerns you have. The conversations may include members of your IT staff who work with CDA, project managers, senior leaders, and other colleagues in your company whose work includes CDC-related assignments or tasks. If you would like to schedule an individual vendor meeting, send an email to the NHSN CDA mailbox, and we will work with you to set up a specific date and time. Next slide. Next, Dr. Janetta Bell will discuss long-term care surveillance.
Hello, thank you. Again, my name is Janetta Bell, and I am the team lead for the long-term care facility component of NHSN. Today, I will briefly present a project that we're working on for a long-term care facility or LTCF data submission to NHSN. However, before I describe the details, I would like to share some background information with you to help explain the rationale for the project. Next slide, please. In 2012, the long-term care facility component or LTCF component of NHSN was launched. 3 years later, in 2015, we had only about 300 facilities enrolled. Today, thanks to an existing partnership we have with a sister government agency, also known as CMS, we now have over 3,200 facilities enrolled, with the majority of those being nursing homes. This group of nursing homes represent about 20% of U.S. nursing homes, but we have a goal of eventually enrolling all of them in the future. Working with these 3,200 nursing homes has opened our eyes to a few challenges they experience while manually submitting data to NHSN. This is particularly important to note because many of the facilities voluntarily report and have no mandate or financial incentive like long-term acute care facilities. Therefore, if the challenges become too burdensome, they may report inconsistently or elect to drop out. Some of the challenges they experience include what I have listed here on the slide. There's frequent staff turnover, few specialized staff dedicated to surveillance, or in some cases there are no staff dedicated to surveillance, several competing priorities within the facility itself, and the perception that surveillance is duplicative and disruptive to their current workflows. We've also learned that many nursing homes have adopted electronic health record systems over the past several years, but it remains an underutilized resource. Although adoption of EHR systems among nursing homes lag behind acute care hospitals, it is a promising solution to the data submission challenges that I just described. Next slide, please. And thus, we have decided to initiate a project to establish an EHR system vendor-neutral standard for submitting data electronically to NHSN. The overarching goal is to develop a method for electronically submitting surveillance data to NHSN that leverages pre-existing LTCF workflows and eliminates duplicative documentation of HAI events. The partners involved in this include CDC, Lantana Consulting Group, LTC EHR system vendors, and the HL7 Structured Documents Working Group. We are at the very early stages of developing this project, so if you have any questions or interest, please contact us. There is some contact information that will be available at the very end of this presentation. Thank you.
Thank you, Dr. Bell. Next, we will review some NHSN updates. Next slide. I'll quickly highlight some upcoming changes and updates in NHSN, starting with some brief announcements about our release schedule. We are going to continue one major release a year, as in the years past. This release go live is January the 1st. It will include NHSN surveillance protocol changes that go into effect with the new calendar year, and also to transition to new CDA versions that are due in part to the protocol changes themselves. In addition, there are 4 scheduled non-major releases a year that may include defect resolutions, minor change requests, infrastructure maintenance, and support. Next slide. We have 4 releases scheduled for 2018, starting with release 8.9, which is planned to be deployed on April the 28th. We have a few defects and CRs that will be included in this release and will be effective immediately post-deployment. Release 9.0 is scheduled for July 2018 and will contain only the outpatient component. We will discuss more about the outpatient procedure component in the webinar. Release 9.1 will be mainly a maintenance and defect release. And then finally, Release 9.2 is scheduled for December 2018 with an effective date of January the 1st, 2019. Defects will be effective immediately post-deployment, and CRs will be effective from January the 1st, 2019 and forward. Next slide. NHSN now provides a defect list on our webpage. The link can be found on the main page of the NHSN website under About NHSN and the Release Management link on the left. This list will be updated periodically. Next slide. In addition, the NHSN program will be shifting to a new help desk system. You'll still use the same email addresses for any issues and questions that you may have. This new system is based on a ticket number, which will allow better tracking for us and is tentatively scheduled for summer of 2018. Next slide. Next, we'll review patient safety related items. Next slide. Getting started with patient safety 8.9 release, a few defects corrected are 5049. It's related to an import issue with MDRO summary not importing correctly and showing a misleading error. This has now been corrected. Next is 5070, was showing an incorrect error when the right criteria was selected for an SSI with the specific event lung. 5074 is updates to the ICD-10 codes and CPT codes. A few codes were added and a few were removed. Next slide. Defect 5101 is related to CDA import. When the drug result for cefepime was S-DD, the data was not saving, and this has also been corrected. Defect 5105 issue was due to APRV days still being required for SCA or ICU Summary CDA import, when actually APRV data is optional for 2018. Next slide. For 5137, when GIT Rule 1A criteria was selected, error message saying criteria selected not applicable was being displayed, and this has also been corrected. Next slide. CRs going into 8.9 are the following. CR 1709 is updating the rules for Group B strep to not be allowed to be reported for CLABSI for the first 6 days of life. Next slide. CR 1863 was actually not implemented. NHSN will keep the rules the same as currently used for the Medicare beneficiary number, which allows 6 to 12 alphanumeric and up to 15 characters total for that field, including hyphens. Next slide. Moving on to 9.2 release, which will be for January the 1st, 2019. CR 2045 will be for the yearly ICD-10 and CPT code updates. We will continue versioning the ICD-10 CPT codes for each year. However, we are considering not including them in the IDM. The source of truth will be the ICD-10 PCS procedure code mapping to NHSN operative procedure codes located on the NHSN website. We will provide more information on this when available. Next slide. CR 1971 is our yearly update to the pathogen code. Yearly versioning will be continued. Changes include updates to the list of pathogens and corresponding business rules for 2019. We also listed dates as guidance for what pathogen codes tab to follow per year. Next slide. A few notable changes to the pathogens list are the hemovigilance column is being grayed out because the HV uses the complete pathogen list. Parasite and viruses will no longer be valid to report for BSI LCBI. Next slide. Also, there are 3 Enterobacter species that changed genus. You can see them listed here. This affected the MDRO definitions and unusual susceptibility alerts tab, so they have also been updated. Next slide. CR 1676 is for a new CDA import for ventilator-associated event, VAE. This CDA will use the R3D2IG and will be valid for event dates beginning January the 1st, 2019. Refer to the supplemental documents for additional information. Next slide. The next 2 CRs are for BSI, bloodstream infection. CR 1716 is for the following 3 fields will now be required to be answered in a BSI list, and they are listed on the slide. CR 1711 is the update of the BSI CDA from the R9IG to the R3D2IG. You can refer to the following reference documents listed here. The updated BSI CDA will include the 3 fields listed above and an optional comment field. Next slide. CR 1736 is to allow only one SSI to be attributed to a denominator during the surveillance period, and the SSIs should be reported at the deepest level that it occurs. CR 1893 is to add a business rule limiting surveillance period for deep incisional secondary SSI events to be within 30 days. CR 1867 is to remove MDRO and CDI encounters field from MDRO for a fact-wide out location. Due to CDA schema requirements, CDA encounters must be included in the CDA. For now, the user can just enter 0 in the application, will not store that number in the database. We will make this update in a future IG. Next slide. To review the BSI CDA change, BSIs with event dates between 2014 and 2018 must use the R9IG, and BSI CDAs with event dates equal to 2019 must use the R3D2IG. Next slide. Molester slides do not have any CDA impact yet and are just a FYI for now. CR 1822 is the addition of new fields to BSI. They will be optional for manual entry for 2019. BSI will also be moving to the R3D3 IG version in 2020 to include these new fields. Next slide. And lastly, CR 1576 is adding a new event, PED VAE. We did include a tab for this in the 9.2 IDM, but there are no immediate plans for CDA yet. Now I'll hand it over to Wendy.
Thank you, Mindy. I'm going to cover general updates for the AUR module. Next slide, please. As of March 30th, 277 facilities have registered their intent to submit AU and AR option data into NHSN as part of Meaningful Use Stage 3. As a reminder, reporting AU and AR option data into NHSN is just one way your facilities may satisfy the MU3 public health reporting requirements, but it's not the only way. To determine which vendors are certified for the Medicare and Medicaid EHR incentive programs, you can search for yourself using the Certified Health IT Product List, CHPL link provided on this slide. Also is included on the slide is URL for an overview of the CHPL program. Next slide, please. So we've posted a few new resources, mainly for facilities, but you may also find value in them. The antimicrobial use and antimicrobial resistance option FAQs were just recently posted. Also, the AU option annual data validation guidance. Your facilities may reach out to you, particularly as they work through the annual AU validation process. Next slide, please. The NHSN team has been reviewing 2017 AU option data so that we can begin updating the existing STAR models and developing new models with additional location types. Many facilities have received emails regarding potential AU antimicrobial days and days present validation issues. As you can imagine, data accuracy is important. So these facilities may be reaching out to you for assistance, and some may have already, since the deadline for correcting and re-uploading the data is approaching. Next slide, please. We want to provide some clarification regarding same-day duplicates. Same-day duplicates are defined as multiple isolates of the same organism from the same patient in the same calendar day. We want to emphasize that the order of the steps is important. When deciding which isolate to report to NHSN, you would follow the specimen type hierarchy by selecting CSF over blood and lower respiratory over urine. If after that the duplicate isolates are from the same specimen source, you would follow the protocol rules to report the most resistant isolate based on the lab results. We'll be updating the AUR module protocol in the future to make this more clear. Next slide, please. The Society of Infectious Diseases Pharmacists, or SIDP, website contains a list of software vendors that have self-reported successfully submitting data into the NHSN AU option. The URL is listed on this slide. So it's recommended that you as vendors keep information on this website updated. If as a vendor you're not on the list and you have successfully submitted AU or AR data, you're encouraged to contact SIDP to be placed on the list. CDC NHSN team often refers to this website to view vendors that have successfully submitted AU or AR data into NHSN. Next slide, please. The AU Synthetic Dataset Pilot Project launched in early 2017. The purpose of this project is to use synthetic data to ensure that vendor ADT data and medication administration data are aggregated correctly according to the NHSN AUR module protocol. So this project is not intended for testing or validation of CDA files. And 2 vendors have successfully validated the AU pilot synthetic data by loading the test data into their databases and processing it just as they would their own real data, generating monthly summary data for the facility-wide, inpatient, or fact-wide in, and eligible locations. We've also recently created an AU production synthetic data set that includes antimicrobials and routes of administration that are not in the AUR module protocol. So this is a good check to see if a vendor's system correctly excludes this data from aggregation. Additionally, likely in 4th quarter of this year, we anticipate having an antimicrobial resistant synthetic data set, or AR-SDS, ready for vendors to validate. If you'd like to obtain more information or to participate, feel free to contact me. My email address is here, wwise@cdc.gov. We have a 20-minute video that demonstrates uploading the synthetic data set into an example vendor database and then submitting the AU output summary file to the web application for validation. Next slide, please. Next, I'm going to cover 2 defects that will be fixed in the upcoming release 8.9. Next slide, please. We found an issue with AR event logic. Users were receiving an error when trying to import a subsequent CDA AR event file that had the same non-invasive specimen source for the same organism for the same month. The logic was not checking the year, though. It was just the month. So an event imported for a non-invasive specimen source for an organism in, say, January 2018, for example, would not import if that same organism and specimen source was imported for January 2017. So this will be fixed in the upcoming 8.9 release. Next slide, please. So we found an issue where upon import of the AR event file, the HL7 location code was not being validated against the HL7 code that is in NHSN for the specific your code location. So the your code itself was being validated, though. An error message should be displayed indicating the HL7 code to be incorrect, and that wasn't happening. It will be fixed in the upcoming release of 8.9, though. Casey will now present on the NHSN 9.2 updates.
Hey, thanks, Wendy. Hello, everyone. My name is Casey Thompson. I'm going to discuss the AUR updates in release 9.2. Next slide, please. First up, let's discuss the AU updates. Change request 1873 is adding a new drug to the AU option, meropenem vaporbactam. The FDA has recently approved this new drug for use because of its treatment capabilities against CRE. The drug will be optional. It can be added for any year, and it will be included in the new version of the IDM. Next slide, please. Next up is change request 1854, moving delafloxacin from optional to required for 2019. Delafloxacin will be required for all AU CDA files containing data for January 2019 and later. This also increases the number of required drugs for the AU option to 90. Next slide, please. Change request 2014 involves an update to the SAR models, and it has no CDA impact. The current SAR models are based on 2014 data from roughly 70 facilities. Now, with over 700 facilities reporting AU data into NHSN, the AU team will be updating the SARs based on 2017 AU data. All current SAR locations will be included, and a few new locations are being considered for inclusion. Next slide, please. Okay, now let's move on to the AR option changes. Change request 2003 adds many new organisms and drugs to the AR option, including species of Candida, Citrobacter, and Proteus. We also updated the AR drug panels to add and remove relevant drugs. These changes will be in the IDM and will go into effect in January 2019. Next slide, please. Change request 2004 adds new reports for the AR option, and it has no CDA impact. As participation in the AR option continues to grow, users have started asking for additional analysis reports for AR option data. Currently, we have just 2 reports available, a simple event line list and a facility-wide antibiogram report. The new reports will be very similar to the reports currently available for the HAI antimicrobial resistance data, a line list, a frequency table, and a rate table displaying antimicrobial resistant organisms. We also plan to add a new AR bar chart report. Change Request 1875 adds a new AR line list denominator report that will display patient days and admissions. Currently, users are only able to view these numbers by exporting the analysis data sets. Okay, next I'm going to turn it back over to Mindy Durrance. Mindy?
Thank you, Casey. Next slide. The outpatient procedure component, also called OPC, will be added to the application this summer. It is tentatively scheduled for July's 21st deployment. We will update you if that date changes. It will include an event and denominator for same-day outcome measures and prophylactic intravenous antibiotic timing, a new surgical site infection event, and a new denominator for procedure. The SSI and procedure forms are different than those used for the patient safety component. Data entry will need to be via manual entry of and CSV for procedures only. CDA import will be added in the future. This will allow time to make sure there are no form changes before the CDA goes through ballot. Next slide. AM-surge facilities following the patient safety component will have the patient safety component automatically inactivated and the outpatient procedure component automatically activated, also called OPC. Existing SSI and procedure data will be copied to the OPC. This only includes the data in which are common for both forms. This process will occur numerous times until all pertinent data has been copied. In OPC, users will be allowed to view historical data that was copied over, but will not be able to edit. Next slide. In case any of your customers are importing SSI or procedures for AM-surge facility type, let's review some guidance. Based on a July deployment date, procedures occurring prior to August 1st, 2018 should be entered into the patient safety component. Procedures occurring on or after August 1st should be entered into the outpatient procedure component. Do not import AM-surge facility type procedures, CDAs, via direct beginning August 1st, or the data will be stored in the patient safety component instead of the OPC. You will be unable to manually import the procedures into the OPC because the form is different. Next slide. Tentative guidance for SSI is the following. Due to the 90-day business rule, enter or import SSIs linked to procedures occurring prior to August 1st into the PSC. If a SSI is linked to a procedure that occurs on or after August 1st, then it will need to be manually entered into the outpatient procedure component. Just as a FYI, NHSN application rule is that data may be entered into an inactivated facility up to 365 days after it was inactivated. Next slide. So make sure your customers follow the guidance that you will be provided by the SMEs in a few months. At that time, the protocol, forms, and so on will be posted to the main NHSN webpage. Next slide. Let's take a quick look at the form. This is an example of the event and summary form for same-day outcome measures and prophylactic intravenous antibiotic timing. The event form includes same-day outcome measures. Note the fields for patient burn and patient fall, and also the wrong event section that includes fields for wrong side, wrong implant, wrong procedure, and so on. It also includes a question regarding if the patient had an order for a prophylactic IV antibiotic that was not administered. The summary form collects the total number of encounters and contains categories for the prophylactic IV antibiotic timing. Next slide. This is the OPC SSI event form. You will notice that it has some of the same fields used for patient safety. A big difference are the questions on page 2 on how the SSI event was detected. Next slide. This is the OPC procedure form. Once again, a little different than the procedure form in the patient safety component. A smaller list of procedures will be reported for outpatient procedure component. Next slide. Next, we'll review CRs and defects related to the dialysis component. Next slide. The 8.9 Dialysis Changes will be included in the upcoming April the 28th release. They will be effective post-deployment. CR 2011 is to allow the dialysis summary for an AKI location that contains all zeros to be a valid entry or CDA import. Note that when dialysis summary CDAs is all zeros, a value for number of patients for whom dialysizers are reused is required in the CDA due to the schema. Defects that will be fixed are the current month's AKI location showing in missing summary alert, the AKI confirmation not correctly being switched from yes to null, and the dialysis event 21-day rule violation. Next slide. Next, we'll review dialysis changes for the 9.2 release, which is for January 2019. The changes will occur for events and summaries that are greater than or equal to January the 1st, 2019. For CR 1928, a pediatric outpatient hemodialysis clinic will be added for dialysis facilities that only serve pediatric patients. Facility type equals AM Hemo PED. For CR 1929, the dialysis event date is required to be greater than the patient's date of birth. And then also CR 1976 includes enhancements to the business rules for ESRD and AKI. Please refer to the dialysis protocol for details. Next slide. You'll be happy to hear that there are no dialysis version changes for January 2019. Just a reminder, dialysis summaries with dates equal to or greater than 2017 must use the R3D1 version of the IG, and dialysis events with event dates equal to or greater than 2018 must use the R3D1.1 version of the IG. Next slide. Next, we will discuss the flu CDA that is part of the healthcare personnel safety component. Next slide. Influenza vaccination summary will be a valid CDA import for 2019. It is also referenced as just the flu. It is included in the healthcare personnel safety component. It will be a valid CDA import for January the 1st. So that means you will be able to import the 2018-2019 influenza season summary via CDA import. For your development, the HPS component will need to be added to your CDA test facility. The facility administrator has user rights to perform this task. For facilities in which a CDC staff member is the facility administrator, we are in the process of adding the HPS component to your test facility, beginning with the NPPT site first. If you have questions or run into any issues, just send us an email. Next slide. The flu CDA will be based on the R3D2 implementation guide. We distributed the R3D2 IG package, but it does not include the HTML format. The link to the IG on the HL7 site is listed on this slide. Remember, you must log in to the HL7 site to be able to download the IG. To assist with your development, we have included supplemental documents in the package. There is a separate HPS IDM. You do not need to wait on the version 9.2 IDM because there are no changes to the fields or business rules. Also included are the mocked-up flu paper form and the flu summary mappings. The flu XML sample is included in the R3D2 IG package. Next slide. This is a display of the flu summary form. The data is stratified, which is similar to how the NICU summary is designed. Next slide. Next, we will discuss some miscellaneous updates. Next slide. CR 2032 pertains to the Hemovigilance Summary CDA, in which ISBT codes will be added. Refer to the supplemental document for the updated blood product ISBT value set. For 2018 data, the HV Summary CDA is based on the R3D1.1 IG. As of today, no facility has imported a HV Summary CDA. Feel free to reach out to us if you develop the Hemovigilance Summary CDA, and we will be happy to set up a Q&A meeting. Next slide. For CRs 1963 and 1811, enhancements will be made to the location export file. Columns for the CMS IPF and IRF and the CCN will be added. Also, the month and year that a location was made inactive will be displayed. Just a reminder, to export the location list, log into the facility. From the left blue navigation bar, select facility and then location, and then click on the Export Location List button. The screenshot shown gives you an idea of how the data will be displayed. Next slide. Next slide. There we go. Thank you. Due to a vendor request, the length of the CDA version number has been increased from INT to long. Now we'll talk about the CDA import data comparison. This slide is a display of the percentage of CDA imports versus manual entry or CSV import for procedures. The year-date range was selected to include completed quarterly CMS reporting. We plan to run this report 4 times a year based on the completed CMS reporting date, and hopefully we will see the CDA percentages increase. Besides AU and AR, which are 100% CDA import, notice that Lab ID and dialysis events are the highest at 54 and 66% respectively. The MDRO summary is the lowest at 6%. Next slide. Just a quick update on direct CDA automation. We are up to 14 vendors and about 5,900 facilities sended via direct. For those of you who don't do direct yet, it is a batch submission process with no immediate reply. The turnaround time is based on volume of messages in the queue. If you are new to direct or want to learn more about direct, there is a direct toolkit on our NHSN website. Before you start your process, we recommend that you schedule a call with us. We'll be happy to discuss the process and recommend best practices. A developer and direct administrator join the call for technical discussion. Next slide. CDA support is available on the NHSN website. The 8.9 IDM has been posted on the website. We added a few more FAQs, for example, more information on succession management and how to export surgeon codes. We support CDA versions that are valid for the past 2 years. The screenshot shows the guide to CDA versions. The red lines show valid CDA versions for 2018 and 2017. And also important links are provided on this slide. Next slide. The pre-production test site, also called NPPT, is a copy of the NHSN development environment. It now includes analysis and reporting functionality, so antimicrobial use and resistant data may be verified. It does not include direct CDA automation or groups. There are no SAMS credentials required. If you would like to have a test facility in the pre-production environment, complete the form found on the website and email to our mailbox at NHSN CDA. Next slide. For those of you who already have a pre-production test site, it has been moved to 8.9 environment. It will be updated in a few weeks to the final 8.9 code. We will send out an email to let you know. As a reminder, at the login, read the important message. There is no effective date for 8.9. To test 2018 related changes, use January the 1st, 2018 to the current date. Version 9.2 code is scheduled to be deployed to NPPT late October of this year. And as always, your feedback is very important and assists us in improving changes and correcting issues. So thank you. Next slide. Next, we're going to talk about future CDAs. Next slide. As we discussed today, 2 new CDAs will be available for import beginning January the 1st, 2019. They are the VAE and Flu Summary CDA. The BSI event will move from the R9 to the R3D2 version and will include 3 new fields. Planned for 2020 are the updates to ICU Other, NICU, SCA, MDRO, and Dialysis Denominator, CDAs, to include Report No Events. The BSI event will be updated to include a few more fields. All of these will be based on the R3D3 IG that will go through the May ballot. A neonatal component will be added to the NHSN application summer of 2020. It will include patient-level event and denominator for late onset sepsis and meningitis. It will be CDA import only. Next slide. Just a few reminders. As always, we welcome feedback. We offer individual vendor conference calls. Make sure you're on the NHSN CDA email distribution list. To be added, email the NHSN CDA mailbox with your request. And also be sure to visit our CSSP site. Next slide. This concludes our webinar for today. Thank you so much for joining. And now we can stop the recording.